Stop for a moment, because I want to ask you something that sounds simple but is one of the most consequential questions in all of medicine, in all of public health, and in the daily lived experience of over 1 billion people on this planet. What does disability actually mean? Not the legal definition, not the checkbox on a government form, not the word that appears in a diagnosis letter or an insurance claim or a parking permit application. I mean, what does it actually mean biologically, neurologically, socially, and personally for the human being living inside a body or a mind that the world was not entirely designed for? Because here is what I have learned in decades of clinical practice and research. The way we define disability determines everything. It determines how conditions are treated. It determines what recovery looks like and whether it is even considered possible. It determines how patients are spoken to, what they are told to expect, and how much of their own potential they are encouraged to believe in. And for the hundreds of millions of adults over 60 who are living with conditions that qualify as disabilities, whether they use that word for themselves or not, the definition they have been handed may be one of the most limiting things that has ever happened to their health. Today, I'm going to give you a complete, honest, scientifically grounded answer to that question. And in doing so, I am going to dismantle several assumptions about disability that are not just outdated. They are actively harmful to the people living under them. If you are new to this channel, I am a physician and researcher who has spent decades studying how the aging body navigates health challenges that the medical system was not always designed to address with the depth and nuance they deserve. The science I share on this channel is referenced in peer-reviewed literature. Every claim I make today has a foundation in research, and the links are in the description below. Before we go further, I want to hear from you. Tell me in the comments right now, do you consider yourself disabled? Has that word ever been offered to you by a physician, and if so, how did it land? Drop your age and your answer below. I read every single comment, everyone. And what you share here shapes what this community learns together. Here is the structure of today's video. I am going to walk you through 5 layers of what disability actually means, moving from the most surface level understanding all the way down to the deepest, most personally relevant truth that the research and the clinical evidence support. We are counting down from 5 to 1. And I want to tell you right now, number 1 is a reframe so fundamental, so supported by current science, and so rarely communicated to patients that I believe it has the power to change the trajectory of how you think about your own body and its possibilities for the rest of your life. Stay with me. Every layer matters, and the last one matters most. Let us begin with the history. Because you cannot understand what disability means today without understanding where the word came from and what it was built to do. For most of recorded medical history, disability was defined through what is now called the medical model. The medical model is simple. It says that disability is a problem located inside an individual body or mind. Something is broken, something is deficient, something has deviated from the norm. And the goal of medicine is to fix it, correct it, or failing that, manage it. The person with the disability is a patient. The disability is the problem. And the solution, if one exists, is clinical intervention aimed at bringing the broken body as close to normal as possible. This model has produced extraordinary things: surgical techniques that restore function, prosthetics of remarkable sophistication, medications that manage conditions once considered entirely unmanageable, physical rehabilitation protocols that recover function once assumed to be permanently lost. I do not dismiss these achievements. I have participated in them, and they matter enormously. But the medical model, applied exclusively and without nuance, also produces something else. It produces patients who are defined entirely by what their bodies cannot do, who are handed a diagnosis and a ceiling simultaneously, who internalize the message, often unspoken, sometimes explicit, that the goal is limitation management rather than life expansion. And for adults over 60 who receive a disability-related diagnosis at a stage of life when the medical system is already prone to underestimating their potential, this ceiling can become self-fulfilling in ways that are, from a neurological and biological standpoint, genuinely tragic. Now let us count down the 5 layers of what disability actually means. Layer 5, the legal and administrative definition, what it is, what it does, and what it misses entirely. In legal and administrative terms, disability is defined as a physical or mental impairment that substantially limits one or more major life activities. This is the language of the Americans with Disabilities Act, of Social Security Disability Insurance, of the World Health Organization's International Classification of Functioning Disability and Health, and of most insurance frameworks globally. It is a definition built for a purpose: to identify individuals who qualify for legal protections, financial support, and reasonable accommodation. And within that purpose, it serves a legitimate and important function. Legal definitions of disability have expanded access to education, employment, healthcare, and public life for hundreds of millions of people. The ADA alone transformed the physical and institutional landscape of an entire country. These protections matter. They are not trivial, and for adults over 60 who may be navigating disability for the first time and need to understand what they are entitled to, knowing the legal definition is genuinely important practical knowledge. But here is what the legal definition cannot capture, and what the clinical evidence makes clear it was never designed to capture. It captures what a body or mind cannot do at a fixed point in time. It says nothing about trajectory, nothing about potential, nothing about the extraordinary variability in how the same diagnosed condition affects different individuals. Nothing about neuroplasticity, nothing about the role of environment, nutrition, social connection, and psychological state in determining functional outcomes. Nothing about the difference between what a body is doing today and what it is capable of with the right conditions and the right support. A legal definition is a snapshot. The human body is a motion picture, and treating the snapshot as the final answer is one of the most consequential errors in how disability is communicated to patients. The synergy tip here is this: know your legal rights thoroughly. Pursue every accommodation, every protection, every financial support you qualify for without hesitation, because these systems exist for you, and accessing them is not weakness, it is intelligence. And simultaneously, refuse to allow the administrative snapshot to define the biological story. They are answering different questions, and only one of those questions has a fixed answer. Layer 4. The social model of disability, the paradigm shift that changes everything about where the problem actually lives. In the 1970s and 1980s, disabled activists and scholars, particularly in the United Kingdom, developed what became known as the social model of disability, and it represented one of the most important intellectual revolutions in the history of how human difference is understood. The social model makes a single but radical distinction. It separates impairment, the physical or cognitive characteristic that a person has, from disability, the disadvantage or restriction imposed on that person by a society that was designed without them in mind. In the social model, a person who uses a wheelchair is not disabled by their legs. They are disabled by buildings without ramps, by transportation systems without lifts, by workplaces without accessible bathrooms, by a physical world built exclusively for ambulatory bodies. Remove those barriers, and the disability, as a social experience, is dramatically reduced or eliminated, even though the impairment remains unchanged. This is not merely political philosophy. It has direct clinical and psychological implications that the research literature has been documenting for decades. A comprehensive review published in the journal Disability and Rehabilitation found that individuals who understood and internalized the social model of disability showed significantly lower rates of depression, greater self-efficacy, and better rehabilitation engagement than those who operated exclusively within a medical model framework. They were not denying their impairment. They were accurately identifying that a significant portion of their daily struggle was environmental and social, not bodily, in origin, and that accurate identification changed what solutions were available to them. For adults over 60 who acquire a disability later in life through stroke, through progressive neurological disease, through injury, through the accumulating weight of chronic conditions, the social model offers something the medical model rarely does. It offers a place to locate frustration that is not their own body. The difficulty navigating a medical appointment is not proof of incapacity. It may be proof of a system not designed for their needs. The exhaustion of managing daily life with a disability is not weakness. It may be the entirely rational response to an environment that requires disabled people to expend extraordinary additional effort to accomplish what non-disabled people accomplish without thought. I think about a patient I will call Thomas, 71 years old, former architect from Seattle, Washington, who had acquired a significant visual impairment over 3 years from a progressive retinal condition. He came to me in a state of profound demoralization. He had been an extraordinarily capable, creative, independent person his entire life. And the medical conversations he had been having were entirely focused on what he could no longer do, on loss, on limitation, on management of decline. Nobody had talked to him about screen readers that had transformed the professional lives of blind architects. about the extraordinary adaptive technology available for his field, about the communities of visually impaired professionals who are producing remarkable work, about the research showing that the spatial reasoning centers of his brain were almost certainly reorganizing, strengthening in response to reduced visual input in ways that were measurable and functionally significant. We talked for 2 hours. He left that appointment and immediately contacted a blind architects network that he had not known existed. 6 months later, he told me, I was grieving a life I did not have to lose. He was right. And the social model gave him the conceptual framework to see why. Layer 3, the biological reality, what disability actually does inside the body, and why the research on neuroplasticity matters more than almost anything your physician has told you. Here is where I need to speak to you with complete scientific clarity. Because there is a version of disability discourse, well-intentioned, politically important, and socially valuable, that in its most extreme form can inadvertently minimize the genuine biological realities of what disability does inside a human body. And as a physician, I cannot allow that minimization to go unaddressed. Because the people sitting in front of me living with disability deserve both the social model's insistence that they are not defined by their impairment, and the biological truth about what is happening inside their bodies and what is genuinely possible in response to it. Disability, regardless of its cause, creates measurable biological changes. Chronic pain elevates cortisol and suppresses immune function. Reduced mobility accelerates sarcopenia, muscle loss, and reduces the mechanical loading that maintains bone density, joint health, and cardiovascular conditioning. Neurological impairment disrupts the gut-brain axis, alters neurotransmitter production, and frequently produces the mitochondrial dysfunction I described in my previous video. These are real, they are documented, and they deserve real clinical attention. But here's what the research also says with equal clarity: the brain is not fixed, the body is not static. And the ceiling that disability appears to impose is, in a remarkable number of cases, far lower than the biological reality of what is possible. The concept of neuroplasticity, the brain's ability to reorganize itself by forming new neural connections throughout life, has transformed neuroscience over the past 3 decades. What was once considered permanent damage is now understood in many cases to represent a starting point rather than an end point. A landmark study published in the journal Neurorehabilitation and Neural Repair found that stroke patients who received intensive rehabilitation and targeted nutritional support showed measurable brain reorganization, documented on functional MRI, up to 5 years after their initial injury. 5 years. Long past the window that older clinical models suggested was the limit of neurological recovery. Research from the University of California, Los Angeles found that consistent aerobic exercise, even gentle zone 2 cardiovascular activity, increased hippocampal volume and BDNF production in adults with neurological disability, producing cognitive improvements that defied the prognoses their original diagnoses implied. A 2020 review in Nature Reviews Neuroscience documented that the gut microbiome, which I have discussed at length in previous videos, directly regulates neuroplasticity through its production of BDNF precursors and its modulation of neuroinflammation, with implications for recovery from virtually every neurological disability condition. I want to pause here and speak directly to everyone watching. If what I am sharing today is giving you something you have needed, a framework, a language, a scientific basis for the belief that more is possible, please take 5 seconds right now and click the subscribe button and the like button below. I publish new evidence-based content every single week specifically for adults navigating health challenges in the second half of life. The algorithm only brings this content to the people who need it when you engage. Please like, subscribe, and share this with one person in your life who is navigating disability and who deserves to hear what the current science actually says. Back to layer 3. The biological reality of disability is real and it deserves real clinical support. And the biological reality of neuroplasticity, of mitochondrial regeneration, of microbiome restoration, of the extraordinary adaptive capacity of the human body under the right conditions is equally real. Both are true simultaneously. And any clinical conversation that presents only one is an incomplete conversation. Layer 2. The psychological and identity dimension, the part of disability that medicine most consistently fails to address. I have sat with hundreds of patients across decades of clinical practice in the moment when they first receive a disability diagnosis. And what I observe in that moment is something that the clinical training I received was almost entirely unprepared to address. I observe grief. Real, profound, physiologically significant grief. The grief of a future that has been revised without consent. The grief of an identity and worker, athlete, caregiver, independent person that is being renegotiated under duress. The grief of a body that no longer behaves as expected or promised. And what does medicine typically do with that grief? It moves past it. There is another patient in the next room. There are treatment decisions to be made. There are referrals to write. The grief is acknowledged with a nod and a pamphlet and occasionally a referral to a psychologist if the schedule allows. And the patient leaves carrying something that has not been named, has not been honored, and has not been integrated into their treatment plan in any meaningful way. This is not a minor oversight. The psychological response to disability is not separate from the biological response. It is the biological response. The research on this is unambiguous. A systematic review published in the Journal of Psychosomatic Research found that depression and psychological distress in individuals with disability was associated with measurably worse physical rehabilitation outcomes, not because the patients were less motivated, but because the neurobiological state of depression directly suppresses the neuroplasticity, the immune function, and the hormonal environment that physical recovery requires. Cortisol, and chronically elevated by unprocessed grief, by fear, by the relentless cognitive load of navigating disability in a world not designed for it, directly suppresses BDNF production, impairs hippocampal neurogenesis, reduces natural killer cell function, increases intestinal permeability, and elevates the systemic inflammatory markers that block tissue repair. The psychological experience of disability is written in the body's chemistry, and that chemistry either supports recovery or undermines it. Research published in The Lancet Psychiatry found that psychological interventions, specifically acceptance and commitment therapy adapted for chronic health conditions, produced significant improvements in physical function and pain management in adults with disability, operating through documented biological pathways, including cortisol normalization and reduced inflammatory burden. These were not soft outcomes. They were measurable, biological, functional improvements produced by addressing the psychological dimension of disability that clinical medicine so often bypasses. I think about a patient I will call Caroline. She was 66 years old, living with a progressive neuromuscular condition in Portland, Oregon. Medically, she was being appropriately managed. But when I sat with her and asked not about her symptoms, but about her life, about who she had been and who she was becoming, she broke down. She told me that she had not cried about her diagnosis since the day she received it 2 years earlier, that she had been managing it, being practical, being responsible. She had not allowed herself to grieve because she was afraid that if she started, she would not stop. I told her something I tell every patient in that situation. Grief is not the enemy of recovery. Suppressed grief is. The nervous system cannot enter the parasympathetic state that repair requires when it is simultaneously holding grief at bay with enormous muscular and neurological effort. The energy spent not feeling is energy not available for healing. We built grief processing into her care plan as deliberately as we built nutritional support and physical rehabilitation. Within 3 months, her rehabilitation engagement had transformed. Her physical therapist noted changes that had not occurred in 18 months of prior treatment. Caroline told me, "I did not know I was spending all my energy holding myself together. When I stopped, I had energy for everything else." And now, layer one. Number one, the deepest, most fundamental, and most clinically important answer to the question, what does disability actually mean? Here it is. After all the legal definitions, the social models, the biological realities, and the psychological dimensions, here is what the current science, the longitudinal research, and 4 decades of clinical observation have taught me. Disability actually means at its most essential level. Disability means that a person is navigating a gap between what their body or mind currently does and what the world, and sometimes they themselves, expects or requires it to do. And the nature, the size, and the permanence of that gap is almost never as fixed as the moment of diagnosis suggests. It is a gap that exists in a specific context. Change the context. The physical environment, the social support, the nutritional foundation, the neurological conditions, the psychological state, the quality of clinical care, and the gap changes. Sometimes dramatically, sometimes in ways that defy the prognosis entirely. A landmark 25-year longitudinal study published in the Archives of Physical Medicine and Rehabilitation followed individuals with significant physical disability from diagnosis across decades. The researchers expected to document progressive decline as the primary trajectory. Instead, they found something far more complex and far more hopeful. Functional trajectories were extraordinarily variable. Individuals with identical diagnoses at baseline showed wildly different functional outcomes at 10, 15, and 25 years. And the variables that most powerfully predicted better outcomes were not the medical variables. They were the social connection quality, the psychological self-efficacy, the nutritional status, the sleep quality, the degree to which the individual had been given an accurate and complete picture of what was possible, rather than simply what was most common. Most common is not the ceiling. It is the average. And the average includes everyone who was never told that more was possible, never given the nutritional support their recovering body needed, never had their grief addressed, never connected with a community that showed them a different trajectory, never received the information that I am trying to give you right now. You are not the average. You are a specific person with a specific body, a specific set of biological resources, a specific social context, and a specific set of choices available to you starting today. The research says clearly that those choices matter, that the biological environment you create inside your body, through what you eat, how you sleep, how you move, how you connect, and what you believe is possible, interacts with your diagnosis to produce an outcome that was never fully written in the moment your diagnosis was given. Disability means you are navigating a gap, and the gap is not fixed, not biologically, not neurologically, not socially, and not for you. Here is what I want you to take from everything we have covered today. You are not your diagnosis. You are not your functional limitation at this moment in time. You are a biological system of extraordinary complexity and documented adaptive capacity, navigating a set of challenges that demand the full depth of what current science knows about the human body's capacity for repair, reorganization, and growth. The legal definition tells you what you qualify for. Pursue it. The social model tells you where the barriers actually live. Fight them. The biological reality tells you what your body is doing and what it is capable of. Support it. The psychological dimension tells you that your inner experience is not separate from your physical recovery, so it is woven into it at the molecular level. Honor it. And the fundamental truth, in that disability is a gap, not a sentence, tells you that the story is not over, that the trajectory is not written, that what is possible for your body and your life extends further than the moment of diagnosis suggested. If this video gave you something you needed today, a framework, a truth, a reason to believe that more is possible, please subscribe to this channel right now. Every single week, I bring you information like this that is specifically researched for people navigating health challenges that deserve more than a 15-minute appointment and a pamphlet. Share this video with one person today, someone navigating disability, someone who has been handed a ceiling and told it is a fact. And tell me in the comments, which of these 5 layers of disability's meaning resonated most with your own experience? And has anyone ever told you that the gap is not fixed? I will be reading every single response. I am here. Thank you for being here.